Good afternoon, everyone. Welcome to the fifth session of the Commission and ANA's Fifth Racism in Nursing series. Whether you've been involved in previous sessions or are new to this space, we are so excited to be here and hope that this interactive learning space is a place for you to find guidance and support. This series is brought to you by the American Nurses Association and the National Commission to Address Racism in Nursing, a multi-organizational collaborative of leading nursing organizations examining the issue of racism in nursing and helping all nurses to mitigate the systemic racism. Today's session is one of an 8-part series. You will be able to earn 1.5 continuing nursing education units for attending today's session. Please stay to the end to complete your evaluation and receive the CNE certificate. The Commission and ANA remain committed to driving systemic change within the profession. The Association's recent response to executive orders affecting diversity, equity, and inclusion underscores its dedication to advocating for inclusive policies and combating structural inequities in nursing. ANA continues to work with Congress and federal agencies to mitigate the impact of policies that threaten progress in health equity and workplace diversity. Please scan the QR code to learn more about ANA's public statement, Protecting Healthcare for Americans. Before we get started, let's review the ground rules for each of our sessions. Remember that this is a brave space. Discussing racism and health equity is difficult and uncomfortable, especially for those directly impacted. Discussions such as these can serve as a trigger. We ask that you maintain respect for everyone joining us today. Please stay on mute until it is your turn to speak. Listen intently and respond thoughtfully. Be present. Limit background distractions and multitasking. Take advantage of the virtual features available via Zoom. We encourage you to turn your camera on and use the chat box or the raise hand features to communicate with the group, but remember to mute your microphone when others are speaking. Please respect participant privacy. Do not disclose names or other sensitive information shared. If you share a scenario involving a patient, do not provide personal information during today's call or any of our sessions. Because of what we are trying to achieve with this education session and the desire for a brave space, ANA reserves the right to remove anyone who, in our judgment, is not adhering to these ground rules. And please note that the chat will be closed during the speaker's presentation. Today's session, Healing the Hurt, Addressing Racism in Nursing, will be presented by Dr. Deborah Toney and a panel of experts, Doctors Angie Milan, Marlon Garzo-Soria, and Deborah Stamps. I will now turn this presentation over to them.
Good afternoon. Welcome to today's session, Healing the Hurt, Addressing Racism in Nursing. I'm Dr. Deborah Toney, your facilitator. I have over 40 years of experience as a nurse. I am the immediate past president of the National Coalition of Ethnic Minority Nurse Associations and currently serve as the executive director. I represented NCMNA as a co-lead for the National Commission to Address Racism in Nursing and contributed to the practice chapter in the foundational report. Diversity, equity, and inclusion, DEI, touches every part of healthcare organizations. It acknowledges the value of many voices and holds well-being of nurses as a central positive clinical environment. Data indicates that nurse retention at an organization is associated with how nurses perceive the value their employers, managers, and peers place on diversity, equity, and inclusion. A successful healthcare workplace must have an inclusive environment and offer safe spaces for bold and fearless conversations. Racism does hurt us all. Nurses have to be able to discuss racism openly and explore how unconscious bias can negatively impact their decisions. Organizations have a responsibility to mitigate barriers hindering these values and must respond to acts of overt and covert racism as part of systemic change needed to address health disparities, especially in marginalized communities. Today's goal is to discuss with the nursing profession to identify, address, and comprehend the impacts of racism on our colleagues, patients, families, communities, and the healthcare system. As nurses, we pride ourselves on delivering compassionate and culturally sensitive care. However, racism in nursing practice negatively impacts patient outcomes, nurse well-being, and the entire healthcare system. With that, I'd like to introduce our esteemed panelists. Each expert will provide a brief introduction, beginning with Dr. Angie Milan, followed by Dr. Deborah Stamps, and concluding with Dr. Marlon Serio.
Good afternoon, everyone, and thank you for joining us today. And just for a quick overview on my background, I've been a nurse for over 30 years. My background is in maternal child health. I began as a staff nurse. I progressed through roles as a nurse practitioner, clinical nurse specialist, nursing professor, and most recently, nursing director in public health program in Los Angeles County. So the majority of my career has been a nonprofit healthcare system. This is by a deliberate choice to serve the community that I call home. This commitment has shaped me into a passionate advocate for the underserved and underrepresented populations. I have had the honor of serving as president of the National Association of Hispanic Nurses and now as president of the National Coalition of Ethnic Minority Nurse Associations. So I feel like I deeply understand the critical importance of diversity in nursing, as emphasized in the Future of Nursing 2020-2030 report, which I was part of the committee, that the healthcare system must prioritize increasing workforce diversity and ensuring that nurses are equipped to deliver culturally relevant care. So I believe that to truly advance these goals, we must actively address and dismantle racism and stereotyping within the profession. And only then can all nurses fully realize their potential and serving every community. Thank you.
Good afternoon, and thank you so much for the opportunity this afternoon to speak with all of you. My name is Deborah Stamps. I'm the founder and chief executive officer of Deborah Stamps Consulting. I have just over 40 years of progressive healthcare leadership experience, where I have held various roles and positions from assistant vice president for quality and patient safety, chief nurse executive for a large health system, and also the founding president of the Rochester General College of Health Careers. I've held the role of inaugural chief diversity officer for the health system, and my passion is on ensuring that individuals from underrepresented communities have access to great health care because they're informed and educated, and also that we increase the diversity of our workforce.
Great. Good afternoon. Good afternoon, everyone. And I echo the thanks to the American Nurses Association for this opportunity to be here, and to Dr. Deborah Tony and Angie Milan from NCIMNA for inviting me to be part of this panel. My name is Marlon Seria. I am the president of the Philippine Nurses Association of America. About just a little over 25 years of nursing experience. Was trained, educated as an oncology clinical nurse specialist. Have since moved to a magnet program director role and a nurse scientist at Providence St. John's in Santa Monica, California. Also serving in the Air Force, Lieutenant Colonel in the Air Force Reserves. Uh, Having said that, I would like to just give a disclaimer that what I say here is Marlon's area, and I'm not representing any of those other organizations. And looking forward to hearing the conversations and the discussions this afternoon. Thank you.
All right, so as you can tell, we have some sure enough experts here today. So panelists, we're going to just get right into it. Dr. Milan, what is racism in nursing, and what are the impacts on patients and healthcare professionals?
So a basic definition of racism in nursing, it refers to prejudicial attitudes, behaviors, and structural barriers that discriminate against individuals or groups based on their race, ethnicity, or national origin. But that's not just it. It also includes gender, sexual orientation, disabilities, language, religion, political beliefs, and so much more. And I think that the impact on patient is highly relevant because it directly influences access to care, the quality of care delivered, and the health outcomes. This may include delayed or inadequate treatment, poor communication, and patient education, decreased patient satisfaction and trust. And in my experience, especially as a new nurse, and when I used to work in labor and delivery, an example was when, especially when a patient of color or somebody who looked different, maybe was an obese patient, maybe he looked, for example, maybe homeless, who had just delivered a baby, would continue to express that they were in terrible pain and that it felt different. You know, the patient was not immediately believed. There was no quick assessment done until the patient actually began to hemorrhage, or when they figured out that it was some type of other complication. And regarding the healthcare professionals, there's many impacts on healthcare professionals or nurses, which may negatively impact the profession's well-being. And this can include decreased job satisfaction, increased burnout, in addition to limited career advancement opportunities, which you hear many of nurses of color state. And of course, this leads to higher turnover rates, nursing shortages. And I just read the other day that according to the U.S. Chamber of Commerce, we'll be experiencing a nursing shortage in 42 different states by 2030. So yes, racism has many, many negative impacts on patients and healthcare workers.
Thank you for that, Dr. Milan. And I'm sure all of us can relate to some of the things that you mentioned, especially when it comes to the patients that we are taking care of and how our education and training doesn't matter. So thank you for that. I'm not sure if any of our other panelists want to chime in on that briefly. Okay, if not, we're going to jump right into our second question, and that's for Dr. Stamps. How does racism manifest between colleagues and the nursing workforce?
Thank you so much, Dr. Tony, for that question. You know, we often enter nursing as a profession with a desire to heal, to comfort, to advocate. But unfortunately, what really happens in spaces that are meant to heal, there's a lot of hurt that goes on. And when we think about the healing spaces of hospitals, clinics, nursing education, they're not immune to the hurt. In fact, racism in healthcare often can be subtle, not always, but subtle. It can be institutional, and it can be really devastating, not only in overt acts, but in the acts that gets heard, that gets believed and gets dismissed. You know, when we work with our colleagues, sometimes we see that we get the different assignments, or we're taught assessments in ways that have bias that are brought into that. When I was a nurse executive and a nurse leader, you know, we hold a unique responsibility, and it's not just to guide the policies. We have to really shape the culture of care, and that care includes not only the care of our patients, but the care of our team, our nurses. And when we have a culture that can either silence injustice or confront it with integrity, we have the choice and the responsibility as leaders. You know, bias is often begins at the bedside. We've seen it all. I'm sure we all have stories of where we've seen patients labeled as drug seeking without justification because they report having pain, and their pain reports are dismissed, or that their cultural factors are overlooked in assessments. These aren't just individual errors, they are systemic patterns that can delay treatment, diminish trust, and tragically cost lives. As a nurse leader, I have challenged normalization of bias in clinical decisions. When we look at machine learnings, when we look at how we hire and promote nurses within the environment. I can go on and on, but I'm going to pause there and let my colleagues continue. But it starts at the bedside, but that's not the only place it is.
You know, Deb, you bring up some very good points. And like you say, I'm sure all of us can think about when we got in the profession and really want to do a great job. And I think about being the first nurse of color, the first Black nurse in the intensive care unit. Now, don't ask me how I got in an intensive care unit when I first got out of school, but that's where I wanted to go. But it does become lonely because nobody, you know, I always thought they were all best friends. They knew each other. They go to lunch and, you know, so you would get you would get left out. They'd be in the break rooms talking to the doctors and, you know, all of those type of things. So it does get to lonely, but it also is not a very good feeling.
No.
So anyway, anybody else want to, Marlon or Angie? All right. So, Dr. Saria, as we think about solutions, what best practices can we implement?
Thank you, Dr. Tony. How much time do we have? I'm sure
Maybe 10 minutes or so.
I'm sure there's a lot.
You don't have
There's a
enough
lot.
for everything you can
I
say.
know, exactly. We have a lot of experts on this webinar. I'm sure there's a lot of experts on this webinar who can share best practices, and that's why I'm really looking forward to the small groups breakout sessions to hear those voices. But in terms of experience that I've had, these are some of the things that I thought worked in some of the situations I have been in. I made a disclaimer earlier. I'll make another one. I am from California. I know with the executive orders, every state has different responses to those executive orders, whether you can have a DEI organization or not. So having said that, I am from California, and I am employed in an organization that has continued to support DEI initiatives. The first thing I'll say is we need to continue the conversations. This is extremely important. What we're doing this afternoon is extremely important. Create a platform to allow crucial conversations, however you can make that happen in your organization or wherever you are. We need to address racism in practice. We need to have the conversations. I have been asked before, how and where do we learn about diverse cultures, traditions, practices? We either read about them, we hear them from other people, but the best experience is working with each other, working with diverse cultures. And if we don't talk to each other, if we don't have those conversations, we lose a lot of that opportunity to learn from each other. Diverse hiring practices, easier said than done. What's diverse hiring practices, right? Actively recruiting and retaining nurses from diverse backgrounds. I think we need to really first look at our job descriptions. Look at the language, inclusive language in our job descriptions. Expand our recruitment channels. I work in Santa Monica, and with what's going on in Los Angeles in terms of traffic, it's very hard to get staff from outside of Santa Monica. And so we get what we get. The enclave of Santa Monica and those who work around the hospital are who will apply to our hospital, those who are not willing to make the 2-hour commute to the hospital. But how do we get other communities? How do we get other staff of color to come to the hospital? Obviously, there's not a magic sauce. We need to work with HR. Bias-free hiring practices. I think many of us know what that would look like. Probably already have implemented those in some of the organizations. I'll share with you a story that happened in my organization when we were looking at leadership in my hospital. They knew I was the DEI co-chair, and that's another story on its own. I was asked to be a DEI co-chair, busy with my work with PNAA, the Philippine Nurses Association of America as president. I am the magnet program director, and we are submitting our first magnet application, and I was asked to co-chair the DEI council. I couldn't say no. I'm the president of an ethnic association. I need to set an example. Like, this is an opportunity for me to use my voice and use it in an organization where I can help others. So again, there's a lot of other things. I'll go along with my other co-speakers. We can have those conversations later in the breakout rooms. But there's a lot of things that we can do, and I think it's really great if we could learn from each other and what those solutions or best practices are.
Thank you, Marlon. Dr. Stamps, I know you have a special interest in how organizations are structured, the tests and those type of things. Can you share a little bit about that?
Yes, thank you so much. A couple of things, I just want to touch back on the bias piece, because even though I stated that it doesn't start at the bedside, it's really manifested in the assessment tools that we use, the clinical protocols, and the standardized evaluations. They're rooted in biased assumptions. And racism becomes embedded in care when every tool that we use assesses patients were never validated across diverse populations. And I'm just going to give a couple examples. Oxygen saturation monitoring. It reads inaccurately in darker skin, leading to missed hypoxia. The Braden scale for pressure ulcer risk doesn't account for how early breakdown occurs in medium to dark skin. We know that there's race-based EGFR adjustments that delay life-saving treatment for Black patients and Hispanic patients for decades for a dialysis, a kidney transplant perspective. These are not isolated flaws. They're built into algorithms, protocols, and assumptions that we use to treat or think that we're treating the clinical truth. As a nurse executive and overseeing quality, I've actually challenged the root cause analysis process used to get to the root cause of a poor outcome, because we don't always take into consideration the cultural needs of the patient, the racism that's built into some of the assessments that are done, and the presumptual thoughts when it comes to why a patient, didn't get the pain medicine that they needed and so forth. When you think about stereotypes, they sometimes sound like slurs, but sometimes they might sound like a compliment. Oh, she's strong. She doesn't need the pain medicine. He's strong. He's sleeping. She's sleeping. They can't be uncomfortable. She doesn't need anything. He's just not compliant. How many times have we heard that? These assumptions that Black strong women are non-compliant, Latino patients are non-compliant, Asian patients, are non-compliant with their diets, and so it leads to more diabetes. All these things are one-dimensional narratives that erase their pain, their truths, and their voice. As leaders, we have to really come from a deep personal place. I've been a nurse at the bedside, I've been a leader and a nurse executive in the C-suite where I was the only Black nurse, the only Black leader. One advocating for patients who were being ignored or misjudged, mistreated. And I know what it means when your expertise is met with silence. When your input is not only invalidated, but then it becomes valid when someone else echoes what you said.
Yes.
But being the only voice in the room isn't just lonely, it's dangerous. And not for me personally, but for patients, for staff, for the communities in which we serve. Because leadership has to reflect the diversity of the people that we're caring for. We have blind spots that become system failures. And they're not system failures, it's because we don't have the right people sitting in the right seats in the right positions. We can't talk about quality without talking about equity. Racism doesn't just touch our patients, it shapes our workforce as well. Sorry.
I think we can all relate to what you just said. I mean, I'll just say it. I hate it when I come up with something and then nobody pays attention and then somebody else, and I'm like, did I just say that?
Yes.
Sometimes I just call it out. I can't take it.
Yes.
I think we are probably close to or at time, Ruth, to get ready to go into our breakout sessions. And I just really want to thank our panelists